Alright guys, welcome to the second Gatorade video. Today we'll be talking about the approach to hematuria. This is going to be very useful in real life as well as exams. Hematuria is very scary when it happens, so it's important that you know how to manage this well, both by reassuring your patient and also getting to the root cause. So there's two types of hematuria. It's either if you can see it or if you can't. When you can't see hematuria, it's called microscopic. This is only detected on a lab assay like urinalysis. And the laboratory definition is more than 3 red blood cells per high power field. Some places say 4, some places say 6. It really depends on your institution. When it comes to urinary anatomy, obviously there's the upper urinary system. This is anything before the bladder. Once you hit the bladder, you're talking about the lower urinary tract. This is where most urinary tract malignancies occur, in the bladder or the urethra. Renal pathology as well, when it comes to cancer, is pretty rare in this case. One thing you have to know is that if you have gross hematuria in someone over 35, this is cancer until proven otherwise. When it comes to test questions, you can't go wrong with this. There's very few times where it's appropriate to simply reassure someone with hematuria and not do a workup. Hematuria is a lot like chest pain. It's going to trigger a workup. Just keep that in mind. So, unless you've been like a medical assistant or something, you might not be too familiar with what a urinalysis tests. So you can see here, this is what it looks like. You basically ask someone to pee in a cup, and then you put this little strip in their urine and it changes color, and based on that, you either manually go through this or you can have a computer do it. It's going to tell you things about infection, pH, protein, etc. The thing we're concerned about here is blood. So how does a dipstick know that blood is present in the urine? I mean, it seems kind of magical, right? You're talking about a test that costs maybe $10. How does it know that blood is in the urine? The way it knows this is by the pseudoperoxidase reaction of erythrocytes. Basically how this works, you have peroxide and then some color changing compound called chromogen. When it hits hemoglobin peroxidase, the chromogen changes color. Therefore, this will show up on the urine dipstick as positive blood. The one thing to note is that myoglobin, which is released from muscle cells when they are damaged, this will also trigger a positive on a urine dipstick. So you want to keep that in mind. One thing to note is that once you have a positive dipstick for blood, if you want to take this further, you have to look at it under a microscope. So the way this works is you're going to spread a little bit of urine out once you centrifuge it and everything. You're going to put it on a little plate, and then per high power field, you basically look at how many red blood cells there are. And so if there's more than 3, you can typically say that yes, there's blood in the urine. One thing to note here is that if you have dysmorphic RBCs, or the red blood cells are, altered in shape in any way, you can usually say that this is a renal cause of hematuria. If you have very normal red blood cells, but there's a lot of them, it's actually a little more concerning because this means it's below the kidneys, and now you're, kind of worried about bladder cancer. One thing to know about dipstick hematuria, it has a very high false positive rate. For many reasons, you might not even know what caused it, but some things to think about are myoglobin, semen, if you have someone who's menstruating and some of that got into the urine, recent exercise, alkaline urine, or someone who's taking lots of vitamin C. This might be, these days people take a lot of, I can't think of the word right now, the little airborne tablets. People think it stops them from getting the flu or whatever, so they take like 10,000 units of vitamin C. I'm blanking on the brand name, but it'll come back to me. Let's do a case. So we have someone, a 25-year-old male. He was hiking in Montana during the summertime. While he was finishing a challenging hike, he was peeing in the woods. He noticed his urine was a pale red color. His right side hurt a bit. So right here, we're going to, kind of back up and think about this. What are we initially concerned about? I really hope you're saying kidney stone. That would really be the most common reason for this. The patient, once he pees though, he's not really having too much pain. And once he gets back from his trip, he goes to the urgent care. They see blood on the dipstick, and there's 20 to 30 normal RBCs per high power field. They decide to do an ultrasound to check for kidney stones, and while they're doing that, they see increased echogenicity of the renal medulla. This is actually something I wasn't too familiar with, but as far as the diagnosis here, it's kind of interesting. So we see renal papillary necrosis. Now you might be thinking, how does someone who was just in the woods minding his own business get renal papillary necrosis? Now I wasn't aware of this, but when you have someone with sickle cell trait, usually these people are asymptomatic. It's about 5% of the population. I want you to keep that in mind. So the way this works is you have someone, Middle Eastern ancestry, African ancestry, they are chilling, happy all their life, then they go somewhere with low O2. Then they become dehydrated. Now you have a patient who starts sickling, and because they relatively have healthy hemoglobin, you actually don't notice this too much, but the one place where this becomes an issue is the kidneys. So I want you to keep in mind, when someone with sickle cell trait undergoes physiologic stress, they might get papillary necrosis, and they might also get priapism or splenic infarction. So you can see why this is a USMLE favorite, because you have the same scenario, but you can test 3 to 5 organ systems. So basically what I'm trying to say is that you have someone who at sea level is pretty happy. They go somewhere with very low O2, and suddenly they have red urine. Sickle cell trait is something to think about. Now one thing to know, like we talked about with the dipstick, it also tests positive for myoglobin. So when you have someone, for example, crush injury, burn injuries, when you're thinking about rhabdomyolysis, I want you to keep in mind that this could be seen as hematuria, because the blood is red, obviously, and it'll screen positive on the dipstick. But if you're working this up properly, you'll then get the microscope analysis, which will not show red blood cells. So it might be kind of puzzling. This is considered either a false positive or a true positive, depending on who you ask, because myoglobin in the blood is bad, because it's very toxic to the kidneys. It's a very scary slide. This is basically the AAFP workup for microscopic hematuria. I want to point your attention to 3 things. One, you want to look at the yellow arrow here. When you have someone with less than 3 RBCs per high power field, aka you're saying they had a normal urine sample, you don't just let them go home, because the risk of missing bladder cancer is just too high. It's unacceptable. So you're going to repeat the urinalysis 3 times at 6-week intervals. If they're negative on all of those, they're free. But if not, you kind of trigger this whole workup. So now I want you to look at the first red arrow. A good first test for urologic malignancy is always CT urogram. I want you to keep that in mind. If they can't get contrast, if they're pregnant, whatever, then you can do an ultrasound, but it's really not ideal. Once you do that CT urogram, you're going to see a positive finding, and then you're going to move on to cystoscopy. Cystoscopy is the diagnostic test of choice for urologic malignancies. That is super important. Now, once you have a positive, that kind of triggers a whole separate video, so we won't go into it, but the name of the game is basically remove the cancer and do some additional radiation. And then after that, you're going to monitor their urine pretty frequently. So backing up a little bit, why does someone get gross hematuria? There's a couple reasons. Unfortunately, per the AFP article that I was reading, up to 40% of people, I think, you'll never get a known cause. It kind of just doesn't happen again, and they're a little freaked out by it. But some things to think about is, have they gotten catheterized lately? Were they in the hospital for like a serious infection? Have they been on their period recently? Have they had prior radiation? Have they been exercising a lot? These are all things to think about. When we're talking about bladder cancer, that's really the scary one, right? That's what we're worried about here. That's the whole point of this video, is to not miss bladder cancer. If someone is a smoker, that's really what you'll see on test questions. You also want to look at male sex, age over 35, typically age over 50. Chemical exposure to things like aromatic dyes, benzenes, and previous cancer treatment. Honestly, in a test question, they'll make it pretty obvious that they're talking about bladder cancer. Now, obviously, when we're talking about test questions, we have to talk about all sorts of random things. So if you have someone with who they say moved here from Africa or the Middle East and they have blood in their urine, one thing they might be trying to get at is schistosoma bladder cancer. So you'll do like a biopsy or a urine sample, and you might either see eggs in the urine, or if you actually do a biopsy, you're going to see these giant schistosoma organisms. This is associated with squamous cell carcinoma of the bladder. I believe this is in contrast to transitional cell carcinoma, which is more common in America. Now, one thing to know about schistosoma, it's also important in America. So you might have seen, viral videos of people going swimming where they shouldn't, like retention ponds, dirty lakes, and you kind of get this rash along your body, typically on the legs. This is called swimmer's itch, and it's also caused by schistosoma. So this is really how you go above and beyond on these test questions, is you think about one thing and you integrate it to other organ systems or other patients. That's really how you're going to level up here. This is another random one. I actually saw this myself. So an upper middle class mom, she says her urine looks like this sometimes. She brings a picture of the toilet bowl. This is what you see. Doesn't have it right now. She noticed she only has it sometimes. When you kind of get a better history on her, you notice she's been doing this juice cleanse lately, and it kind of happens only when she's doing the juice cleanse. So one thing to think about is beet urea. If someone's eating a lot of beets, to my understanding, it has to be like one of 5 things in your diet. Like it's not just one beet every now and then. It's a lot of beets. So it's harmless, pretty reversible, but if you can identify this by taking a good history, you might save someone a very lengthy workup, so keep that in mind. Now we're kind of getting to our real patients. So we have a 50-year-old man. He presents to clinic with complaint of blood in his urine for the past month. It does not hurt when he pees. This is really a red flag symptom. Painless gross hematuria. It's cancer until proven otherwise. We confirm it on microscopic analysis. What should we do next? We can reassure the patient. We can do a CT scan. We can emergently just cut them open and look for bladder cancer, or we can refer to nephrology. We can say, it's probably caused by your kidneys. I'm going to have someone else look at it. So what should you do next? You can pause here. I'm about to move on. So the best answer, once we've confirmed that the blood is present on microscope, you can do a CT urogram. The nuances of a CT urogram versus a normal CT, kind of outside the scope here, but long story short, you're checking someone's bladder function both while they're collecting urine and voiding it, and you kind of get an idea of various pathologies. So this is what bladder cancer might look like on CT. It's going to be like a little nodule in a relatively normal bladder. There's just one little dot there, like a little acne cyst or something. Once you see this, you're basically doing a cystoscopy. So what you want to keep in mind is that a cystoscopy is the key diagnostic procedure for bladder cancer. It allows the urologist to see inside the body with a thin scope with a light on it called a cystoscope. And this is a transitional cell cancer. You can see it's a very friable mass, looks really ugly, and we can kind of integrate this with our anatomy. If you think about the bladder, it's contracting and relaxing a lot. These cells are very friable. So that's why you get blood in the urine, because little cancer clumps are actually popping off. That's about it for this video. I'm going to be posting a few more of these very shortly. Thank you guys.